So the next important question in the respiratory system is, we have a 60-year-old obese person weighing around 110 kgs. He has been complaining of the excessive sleepiness in the daytime, morning headache, irritability and mood disturbances. Patient also has history of dry mouth, nocturnal heartburn, diaphoresis of the chest and as well as the neck. Which one of the following will be the best investigation to diagnose the patient? First option, ambulatory blood pressure monitoring, 24-hour Holter monitoring, echocardiography and overnight polysomnography, right? So the one which is best, okay, what is this clinical diagnosis suggestive of? This is suggestive of the obstructive sleep apnea. And in case of the obstructive sleep apnea, the investigation of choice is the overnight polysomnography or polysomnogram. Now, you take ambulatory blood pressure monitoring. This is required in individuals who have doubtful in having the presence of the hypertension in them. Ambulatory blood pressure monitoring is being done, and 24-hour Holter monitoring is done in those individuals who are having intermittent ventricular premature contractures or bradyarrhythmias causing fall of the individuals. So in order to pick up that bradyarrhythmia or tachyarrhythmia, we do this 24-hour Holter monitoring. And echocardiography is mainly to assess both right and left ventricular function, and it will also assess any valvular pathologies, and it will also assess the presence of the cardiomyopathies, right? And it is the polysomnogram which will be useful for the diagnosis of the obstructive sleep apnea. Now, if you take this obstructive sleep apnea, this is very common in the middle-aged individuals, right? And this obstructive sleep apnea, this is commonly observed in males rather than females. And the characteristic feature of the obstructive sleep apnea is that it is characterized by the intermittent closure or collapse of the pharyngeal wall, right? Intermittent closure or the collapse of the pharyngeal wall. And this collapse of the pharyngeal wall or the intermittent collapse, that is mainly during the sleep. Now, because of the collapse of the pharyngeal wall, right, or because of the intermittent closure, there will be apneic episodes. And because of this apneic episodes, right, so there will be apneic episodes. Now, because of this apneic episodes, the individual will have the arousal, okay? So now how is this apneic episode terminated by? This is terminated by the partial arousal of the individual, right? This is terminated by partial arousal of the individual. Now, what exactly is the sleep apnea defined as? The sleep apnea is defined as the cessation of breathing, right, where there will be stoppage of breathing during the sleep for nearly around 10 seconds. That is what is called as the sleep apnea. And during this particular, okay, so this is the normal airway. And in patients with obstructive sleep apnea, you can see that there is intermittent closure of the airway. And during this apneic episodes, there is drop in the oxygen saturation, right, by more than 3%. And because of the drop in the oxygen saturation, the apneic episode is the apneic episode is the one which is causing the drop in oxygen saturation, and there will be arousal. And because of this partial arousal, there will be activation of the sympathetic nervous system during that partial arousal. And because of this stimulation of the sympathetic nervous system, these patients develop systemic hypertension, right? These patients will develop systemic hypertension. So there will be rise in blood pressure by almost 5 to 10 millimeters of mercury. That is the complication that you will have in patients with the obstructive sleep apnea. And what exactly is the pathology for the development of the hypertension? That is due to increase in the sympathetic tone, right? So that is due to increase in the sympathetic tone. That is what is responsible for the development of the hypertension. And the consequence of the development of hypertension is there will be increased afterload on the left ventricle, causing left ventricular hypertrophy, and there can be also development of the myocardial infarction, right? Or there can be even development of the hemorrhagic stroke. This will be the consequence of the hypertension. Now, which group of individuals with obstructive sleep apnea have to be treated? So, those individuals with Epworth sleepiness score more than 11, they have to be treated. Next, those individuals, because of intermittent arousal during the night, there will be excessive drowsiness during the daytime. And this particular patient, if they are having troublesome sleepiness, right, if the patient is having troublesome sleepiness while driving, right, or troublesome sleepiness while working, these patients, they have to be treated. And those individuals who are having more than 15 episodes of apnea plus hypopnea during the sleep, they have to be treated. Next, so these are the indications where the individual have to be treated. Now, what are all the various parameters taken in the Epworth sleepiness score? See, these are all the various parameters that are being taken in the Epworth sleepiness score, right? When the individual is having drowsiness, that is sitting and reading easy having drowsiness, watching television easy having drowsiness, and sitting inactive in the public place easy having drowsiness, as a passenger in the car for an hour without a break easy having any drowsiness. So these are all the parameters which are taken into consideration, and if the Epworth sleepiness score is more than 11, they have to be treated. And what are all the various complications that you come across in obstructive sleep apnea is, first and foremost, there can be development of the systemic hypertension, right? And apart from systemic hypertension, the other important complication will be the pulmonary hypertension, right? There can be also development of type 2 respiratory failure. There can be development of the myocardial infarction. There can be development of the stroke, and even there can be also development of the arrhythmia. Okay, so these are the complications of the obstructive sleep apnea. Then what is the way by which you can diagnose this obstructive sleep apnea? That is by polysomnography, right? That is by the polysomnography. So polysomnography is the one which will monitor the oxygen saturation, right? This is the one which will monitor the airflow across the nose and mouth. And then the polysomnography also does the ECG to demonstrate if there is any tachycardia during the apneic events. Then it will also demonstrate the EMG, electromyography. This electromyography is measured at chin and as well as at the leg, that is muscle activity during that apneic episode. Next is the electroencephalograph, that is mainly to demonstrate the cortical awakening. And next important is the EOG, that is electrooculogram, that is mainly to record the ocular movements. That is mainly to record the ocular movements. So polysomnography is the investigation of choice, and this polysomnography will monitor all these. And in the polysomnography, depending upon the number of apnea hypopnea events, we classify the patients with OSA into mild, moderate, severe. Now, when do you call mild? When the number of apnea hypopneic events, right, or the AHI events per hour, if it is 5 to 14, they consider to be mild. And if the number of AHI events, if they are in between 15 to 29 AHI events per hour, then they are considered to be moderate. And if the number of the AHI events, if it is more than 30 AHI events per hour, then they are considered to be severe obstructive sleep apnea hypopnea syndrome. Then in the treatment, if the patient is smoker, the individual has to quit the smoking, and weight loss is a very important part of the treatment. The individual has to at least reduce the weight by almost 10%, right? At least reduce the weight by almost 10%. Then next important is the treatment of choice will be the continuous positive airway pressure. So this continuous positive airway pressure, this works by blowing the airway open, right? So this works by blowing the airway open, right? So once this blows the airway open during the sleep, and what is the pressure at which this CPAP should be administered is, this has to be administered at a pressure of 5 to 20 millimeters of mercury, right? So this is what is the CPAP that the patient has to be attached to when the individual is sleeping. And when the individual is refractory to this medical management or this CPAP, then the surgical treatment that you need to do is UPP, that is uvulopalato-pharyngoplasty has to be done. So this will be the treatment in patients with the obstructive sleep apnea. So this finishes the quick revision of the OSA. Let me just show you one more question on the OSA. Which of the following conditions predispose to the obstructive sleep apnea? Hyperthyroidism, acromegaly, obesity, use of alcohol or sedatives. So hyperthyroidism will not cause the obstructive sleep apnea. Acromegaly, obesity and use of alcohol or sedatives, they are the one which will cause the obstructive sleep apnea, right? So acromegaly is the disorder where there is excessive increase in growth hormone in adults. These patients, they'll have prognathism, and there will be alteration in the structure of the oral cavity that can predispose to the development of the OSA. Then the obesity and as well as the use of alcohol or sedatives, that will decrease the tone of the pharyngeal muscles that can cause the collapse of the airway during the sleep, causing the apneic episodes, right? So that is about the conditions where you will have the presence of the OSA. Then followed by that, the next important question is on the topic of the pulmonary eosinophilia. Which of the following is unlikely to be associated with eosinophilia? Loeffler syndrome, toxocariasis, trichinella spiralis, tuberculosis. So remember, tuberculosis, it is associated with what? It is associated with lymphocytosis but not the eosinophilia. Whereas in Loeffler syndrome, toxocariasis and trichinella spiralis, you have the presence of the eosinophilia. Now let me take up the discussion of the pulmonary infiltrates with eosinophilia, which is nothing but the eosinophilic pneumonia. Now we classify these particular disorders into two, right? What are those? Those conditions where the etiology is known, right? And the second important condition is that where the etiology is not known, that is idiopathic, right? That is idiopathic. Now the conditions where the etiology is known, that we call it as ABPA, that is allergic bronchopulmonary aspergillosis. Number 2, parasitic infestations, right? Parasitic infestations. Then followed by that, the drug reactions and eosinophilia myalgia syndrome. Then idiopathic conditions where you will have the pulmonary infiltrates with eosinophilia is, that is what is your Loeffler syndrome, right? Second important condition is acute eosinophilic pneumonia, and third, chronic eosinophilic pneumonia. Then Church-Strauss syndrome, that is allergic granulomatosis of Church and Strauss, and hypereosinophilic syndrome. So these are all the conditions where you will have the eosinophilic pneumonia, right? Now, if you take the hypersensitivity reaction to the aspergillus, the hypersensitivity reactions to the aspergillus, we classify them into two. Number one, which is IgE mediated, which is also called as the atopic form of the aspergillosis. The next one is non-IgE mediated, right? The next one is non-IgE mediated, that is in non-atopic individuals. Okay, now if you take IgE mediated, that is atopic individuals, the examples are the asthma, right? And second one is the ABPA, that is allergic bronchopulmonary aspergillosis. And non-IgE mediated, this will be extrinsic allergic alveolitis. So in extrinsic allergic alveolitis, please remember the eosinophil counts are not elevated. And in extrinsic allergic alveolitis, they will have normal IgE levels, right? They'll have normal IgE levels, right? And eosinophil counts will be absolutely normal. And you have the presence of diffuse pulmonary infiltrates, right? You have the presence of diffuse pulmonary infiltrates on the chest X-ray. Okay, so that is what is the feature of extrinsic allergic alveolitis. Now let me take up the detailed discussion of this ABPA, that is allergic bronchopulmonary aspergillosis. Now if you take this aspergillosis, we have two species, the Aspergillus fumigatus and niger, and it is the Aspergillus fumigatus that is the one which is associated with pulmonary aspergillosis, whereas the Aspergillus niger that is associated with the external ear infection, right? That is associated with the external ear infection, which is nothing but the fungal otitis media, right? Which is nothing but the fungal otitis media, that is the Aspergillus niger. And this aspergillosis, this is not a contagious disease. It is commonly observed in the immunocompromised patients. Right, in immunocompromised patients, the fungal infections like aspergillosis is very common, and this pulmonary aspergillosis may take four important forms. One is the allergic bronchopulmonary aspergillosis. The second one is the saprophytic aspergillosis, which is also called as aspergilloma, and third important is chronic necrotizing aspergillosis. Right, chronic necrotizing aspergillosis, and the fourth one is the invasive aspergillosis. Right, the fourth one is the invasive aspergillosis. Okay, so this is what is your pulmonary aspergillosis, right? So this invasive aspergillosis, this is observed in severely immunocompromised patients. Right, it is observed in severely immunocompromised patients. Now out of this, you take the ABPA. ABPA, it is a pulmonary hypersensitivity disorder. Right, it is a pulmonary hypersensitivity disorder, and this is caused by allergy to the fungal antigen that is colonizing within the tracheobronchial tree. And this ABPA most commonly occurs in the atopic asthmatic individuals, right? Commonly observed in atopic asthmatic individuals in response to the antigen of the Aspergillus species. And if you take the diagnostic criteria, you have main diagnostic criteria and as well as the minor or secondary diagnostic criteria. Now the main diagnostic criteria is, number one, there should be history of the bronchial asthma. Number two, there should be presence of the pulmonary infiltrates. Right. Number three, there should be increase in the eosinophil count within the blood, and the skin hypersensitivity test that should be positive. Okay. So the skin reactivity to the Aspergillus antigen that should be positive. Next, there should be elevated serum IgE levels. Then followed by that, there will be bronchiectasis, which is the central or proximal bronchiectasis. So these are the main diagnostic criteria. Then what is the, so yeah, you can see this skin hypersensitivity test to the Aspergillus antigen. Then what are the secondary diagnostic criteria? Secondary diagnostic criteria is there should be history of the brownish plugs within the sputum, right? History of brownish plugs in the sputum. And second is there should be identification or culture of the Aspergillus fumigatus from the sputum. So in the sputum, when you do a culture, right, this particular culture should show the presence of the Aspergillus fumigatus, right? Should show the presence of Aspergillus fumigatus, and there should be elevated IgE class antibodies, right? Elevated IgE class antibodies that is specific for the Aspergillus fumigatus. That is specific for the Aspergillus fumigatus. This will be the secondary diagnostic criteria. And if you take the clinical features, patients with ABPA, they have the pre-existing history of the asthma, right? Or there should be a pre-existing history of the cystic fibrosis. And these patients with ABPA, they cause intermittent episodes of wheezing. Because there is pre-existing history of asthma, these individuals, they will have the wheeze, right? And there is also cough with sputum production which is brownish in color, and when you do and there will be also low grade fever, right? There will be also low grade fever. And when you observe the peripheral blood, right, what is that you will observe in the peripheral blood? As I have said you, there should be eosinophilia, right? And patients with repeated, right, patients with repeated ABPA, they develop the central bronchiectasis, right? Patients with repeated ABPA, they develop the central bronchiectasis, and there is progressive loss of the pulmonary function, right? There is progressive loss of the pulmonary function. And ABPA, it commonly involves the upper lobes, right, but not the lower lobes. And do you have the pleural effusion in patients with ABPA? Never. Pleural effusion will not be there in patients with the allergic bronchopulmonary aspergillosis. And the bronchiectasis which you commonly observe in case of ABPA, it is mainly in the upper lobes, and that too bilateral involvement will be there, right? Then how is the spread of this particular the aspergillosis? The spread, it is not a contagious disease, right? It is mainly due to the inhalation of the conidia. That is what is responsible for the spread of this human aspergillosis, okay? And the other one is the nosocomial infection. Nosocomial infection is very common in the immunocompromised patients, right? And if you take the, so this is your main diagnostic criteria. There should be pre-existing history of bronchial asthma, pulmonary infiltrate should be there on the chest x-ray, peripheral eosinophilia, right? There should be skin sensitivity test to be positive to the aspergillus antigen, serum precipitance of the aspergillus fumigatus, elevated IgE levels, and central bronchiectasis. And the other diagnostic criteria or secondary diagnostic criteria is brownish plugs in the sputum. In the sputum, when you do a culture, there should be presence of aspergillus fumigatus and elevated IgG or IgE class antibodies specific for aspergillus fumigatus. This will be the secondary diagnostic criteria. Then when you do a radiology in case of the ABPA, you will have the presence of fleeting alveolar infiltrates. Now, what do you understand by this word, fleeting alveolar infiltrates? See, fleeting alveolar infiltrates mean the alveolar infiltrates, they are not just confined to one particular part of the lung, right? These alveolar infiltrates, right, they spread, right? They distribute throughout the lung. That is what is your fleeting alveolar infiltrates. But predominantly they are distributed over the upper lobes. And these shadows move around the upper part of the lung, and that we call it as the fleeting opacities. Right, that we call it as the fleeting opacities, right? And there will be also the picture suggestive of the bronchiectasis. And because it is the hypersensitivity reaction to the aspergillus antigen, what will be the mainstay of treatment? That is corticosteroids. So corticosteroid therapy is the mainstay of treatment. That is prednisolone, right? So prednisolone is the drug that we give in these patients, right? And one more clinical condition where you will have eosinophilia is tropical pulmonary eosinophilia. So this is a distinct syndrome that develops in individuals who are infected with lymphatic filarial species, right? So who are infected with lymphatic filarial species. And the features of tropical pulmonary eosinophilia is that males, they are commonly affected than compared to that of the females, right? And there should be also history of resistance, right? There should be also the history of resistance in filarial endemic region, and the clinical manifestations will be in the form of cough and as well as wheezing. But this cough and as well as wheezing, that is mainly during the night. So there will be nocturnal cough and as well as wheezing. And these patients, they will also have the weight loss, and they will have a very low grade fever, and there will be also development of the adenopathy, which is nothing but the lymphadenopathy is commonly observed, right? And eosinophilia, how much will be the eosinophil count? That will be more than 3000 eosinophil cells per cubic millimeter. And the chest x-ray in case of tropical pulmonary eosinophilia, right, that will show you bronchovascular markings, And these bronchovascular markings, they are diffuse in the sense throughout the lung fields, right? Or so there will be like increased bronchovascular markings, right, or which are present diffuse, or there can be presence of mottled opacities in the chest X-ray in patients with the tropical pulmonary eosinophilia. And when you do a pulmonary function test in patients with tropical pulmonary eosinophilia, that will show you a restrictive lung disease pattern where the FEV1 by FVC, that will be more than or equal to 70%. And in these individuals, there will be elevated IgE levels, right? Elevated IgE levels. And how is that you will confirm the diagnosis? The diagnosis can be confirmed by marked elevation of filarial antibody titer, right? Marked elevation of the filarial antibody titer, okay? And microfilaria, they are generally not detectable in the peripheral blood, right? Because they are present deep in the viscera during the daytime and they enter into the peripheral blood mainly during the night. Then how is that you will treat these patients with tropical pulmonary eosinophilia which is caused by lymphatic filariasis? That is, you need to give diethylcarbamazepine. That should be given at a dosage of 6 milligrams per kg per day, right? And this should be given in 3 divided doses, right? So this should be given in 3 divided doses for how many days? That is 12 to 21 days you have to give. And this diethylcarbamazepine, it is active against both the microfilaria, right? It is active against both the microfilaria and as well as the adult worms, right? As well as the adult worms. So that is about the treatment, that is diethylcarbamazepine for lymphatic filariasis, okay? So this finishes the question on the pulmonary eosinophilia, right? Mainly you need to be aware of ABPA, allergic bronchopulmonary aspergillosis, and tropical pulmonary eosinophilia, right? The next question is on the acid-base disorders. The most common acid-base disturbance in critically ill patient is chronic respiratory acidosis, chronic respiratory alkalosis, chronic metabolic acidosis, and chronic metabolic alkalosis, okay? So common acid-base disturbance in critically ill patients will be the metabolic acidosis, right? So this critically ill patients, they often experience metabolic acidosis due to various reasons. What are the reasons that will be causing the metabolic acidosis? It could be because of the sepsis, right? This could be because of the renal failure, right? Or this could be because of the tissue hypoxia where the individual will go into anaerobic metabolism causing excessive production of the acid, lactic acid, causing metabolic acidosis. Now, in case of the metabolic acidosis, like what exactly the components that vary completely? So there will be decrease in the bicarbonate levels, right? And compensatory to that, there will be also decrease in the carbon dioxide. So there will be metabolic acidosis with respiratory alkalosis as a compensation, right? The quick recap of the normal values, if you observe, the pH normal value is 7.36 to 7.44, and the partial pressure of the carbon dioxide will be 36 to 44 millimeters of mercury, and the normal levels of the bicarbonate, if you observe, that is around 22 to 26 milliequivalents per liter, right? 22 to 26 milliequivalents per liter. So this will be the normal values, right? And whenever the pH decreases, this we call it as acidosis, and whenever it increases, it is alkalosis. And the levels of the carbon dioxide, they are completely maintained by the lung. So any abnormality within the lung, that we call it as respiratory component. For example, if there is increase in carbon dioxide, right, due to any respiratory pathology, the carbon dioxide will combine with water molecule to form the carbonic acid. So thereby, these patients will develop respiratory acidosis. And due to any reason, if there is decrease in carbon dioxide, where there is tachypnea causing carbon dioxide washout, then these patients will develop respiratory alkalosis. And bicarbonate, if you observe, it is an alkaline substance. And if the levels of the bicarbonate is increased, so the levels of the bicarbonate are maintained by the kidney. So it's a metabolic variant. So if there is increase in the bicarbonate, that will result in the metabolic alkalosis. And if there is decrease in bicarbonate, that will result in the metabolic acidosis. that will result in the metabolic acidosis. So this is about the abnormalities related to the acid-base disturbances, right? And always remember, if the primary event is respiratory acidosis, the compensatory event will be metabolic alkalosis. Second, if the primary event is respiratory alkalosis, the compensatory event will be metabolic acidosis, and vice versa. That is, if the primary event is the metabolic alkalosis, the compensatory event will be respiratory acidosis, and if the primary event is metabolic acidosis, the compensatory event will be respiratory alkalosis. So this is how you need to be aware of the acid-base disturbances, right? Then the next question is on the topic of the respiratory failure. Which one of the following is not a usual cause of a type 2 respiratory failure? Guillain-Barré syndrome, upper airway obstruction, pulmonary embolism, and flail chest. So pulmonary embolism, it is not type 2 respiratory failure. It is mainly a type 1 respiratory failure that you will have in pulmonary embolism, because there is tachypnea in these patients which will cause the carbon dioxide washout. So thereby they'll have hypoxia and as well as the hypocapnia, which is a feature suggestive of the type 1 respiratory failure. Remaining all conditions will cause the type 2 respiratory failure. Now let me just do a quick recap of all the types of the respiratory failure. See, type 1 respiratory failure, this is also called as acute hypoxemic respiratory failure, and in these patients they will have hypoxia and carbon dioxide levels, either they remain normal or decreased in case of type 1 respiratory failure. Then what are the etiologies? So it is acute hypoxemic respiratory failure that is mainly due to the alveolar flooding. So in patients with type 1, the important problem is there will be alveolar flooding. Now what are the etiologies that will be causing the alveolar flooding? That includes the pulmonary edema can cause the alveolar flooding. Next, pneumonia can cause the alveolar flooding. Then the next one is the alveolar hemorrhage. Right, the next one is the alveolar hemorrhage. So these are the etiologies that will be causing the acute hypoxemic respiratory failure. And few more important etiologies are the ARDS. ARDS are the one which will cause non-cardiogenic pulmonary edema. Then congestive heart failure, which will be like cardiogenic pulmonary edema. So and how do you treat? See, whatever is the underlying cause, you need to treat the underlying cause. And apart from that, one more important parameter in type 1 respiratory failure is about the A gradient. Now, A gradient, it stands for alveolar arterial oxygen gradient. So this alveolar arterial oxygen gradient, that will be increased. See, how much is the normal gradient? That is around 5 to 10 millimeters of the mercury. But in patients with type 1 respiratory failure, the gradient increases. So treatment is, you need to treat the underlying cause and you need to place the individual on mechanical ventilator if there is severe hypoxemia. So that is about type 1 respiratory failure. Whereas type 2 respiratory failure, this results from the alveolar hypoventilation. Right, this will result from the alveolar hypoventilation. In these patients, they will have hypoxia and there will be hypercapnia. So in these patients, because of alveolar hypoventilation, there is inability to eliminate the carbon dioxide effectively. That will be your type 2 respiratory failure. Then what will happen to your A gradient? A gradient for the oxygen will be normal in case of the type 2 respiratory failure. Then what are the etiologies or what are the mechanisms for the development of the type 2 respiratory failure? Number one, decreased or impaired CNS drive to breathe. Right? Now, what are the conditions where there is impaired CNS drive to breathe? Number one, drug overdose. That is, opioid overdose will cause respiratory center suppression. Next, brainstem injury, where there is pathology within the pons and medulla oblongata, and sleep disordered breathing, and then hypothyroidism. So these conditions, drug overdose, brainstem injury, like sleep disordered breathing and hypothyroidism, there will be decreased CNS drive to breathe, causing alveolar hypoventilation, and there is increase in carbon dioxide levels, right? And second important is the impaired strength with failure of the neuromuscular function. So either there is neuromuscular junction abnormalities, right, or the respiratory muscle abnormalities, or the pathology within the nerve which are supplying to the respiratory muscles. What are the examples of these? Like cervical spine injury. What will happen when there is cervical spine injury? The phrenic nerve, which is a root value, that is C2, C3, C4, that will get cut off. Thereby there will be diaphragmatic paralysis causing the type 2 respiratory failure. Neuromuscular junction abnormalities like myasthenia gravis. Then next important is muscular pathologies like motor neuron disease and as well as Guillain-Barré syndrome and even transverse myelitis. So in all these conditions, you have the development of type 2 respiratory failure. Infectious pathologies like polio, botulinum, and the conditions wherever there is electrolyte abnormalities causing severe muscle weakness like hypokalemia. Congenital muscular dystrophies like Duchenne's muscular dystrophy. So all these conditions are the one which will predispose to the development of type 2 respiratory failure. So you need to treat the underlying cause and you need to connect the patient to non-invasive positive pressure ventilation. And if the patient is not maintaining the adequate saturation and if the carbon dioxide levels are not decreasing, then you need to connect the patient to the endotracheal tube. Then you need to do the intubation. Right? That is the treatment for your type 2 respiratory failure. Then what is type 3 respiratory failure? Type 3 respiratory failure, this is a form of respiratory failure that occurs due as a result of lung atelectasis. Right? So this occurs as a result of the lung atelectasis. Okay? So this lung atelectasis, this is very common in the perioperative period. Right, so this is very common in the perioperative period. So that is why it is called perioperative respiratory failure. This perioperative respiratory failure, this is more common in obese individuals. This is more common in elderly patients, right? And these patients with type 3 respiratory failure, they will not be able to come out of the effect of general anesthesia. They will not be able to come out of the effect of the skeletal muscle relaxants. So in these patients, there will be collapse of the basal lung segments. Right? There will be collapse of the basal lung segments. And how is that you need to treat? Oxygen saturation is reduced. So these patients, they have to be connected to the mechanical ventilator, and then you need to do the chest physiotherapy in order to increase the strength of the respiratory muscles. Okay, that is about your type 3 respiratory failure. Then type 4 respiratory failure, this is due to decreased perfusion to the respiratory muscles. Okay, so this is due to hypoperfusion of the respiratory muscles. So normally respiratory muscles, they receive less than 5% of the cardiac output. They receive less than 5% of the cardiac output. Now, whenever there is the cardiogenic shock, right? So whenever there is the cardiogenic shock, what will happen? The cardiac output significantly reduces, and thereby the perfusion to the respiratory muscles, that will be reduced. Perfusion to the respiratory muscles, that will be reduced. And once the perfusion to the respiratory muscles is being reduced, then the individual will have respiratory muscle paralysis. Okay, so the etiology for type 4 is the cardiogenic shock. Then how is that you need to treat these patients? They have to be connected to the intubation and connecting the patient to the mechanical ventilator. By connecting the patient to the mechanical ventilator, there will be redistribution of the cardiac output, and thereby respiratory muscle perfusion increases. Okay, so this is about the types of the various types of respiratory failure. So yeah, so this is a form of the chest physiotherapy which is very important in type 3 respiratory failure, and this is the summary of the various types of respiratory failure. So type 1 etiology are ARDS and CHF, common conditions, and type 2 respiratory failure, acute exacerbation of COPD and status asthmaticus, whereas mild to moderate form of COPD, they cause type 1 respiratory failure. And type 3 is perioperative atelectasis, and type 4 is decreased perfusion of the respiratory muscles. So this is the quick revision of the topic related to the respiratory failure. Next. So the next topic for the discussion is about the pleural effusion. Low pleural fluid glucose may be observed in which of the following condition? pyogenic pleural effusion, rheumatoid pleuritis, malignant pleural effusion, hepatic hydrothorax. Select the correct answer using the code given below. So pyogenic pleural effusion, rheumatoid pleuritis and malignant pleural effusion, you will have low pleural fluid glucose, right? So the correct answer is first option. Whereas hepatic hydrothorax is the one which will cause transudative type of pleural effusion where the pleural fluid glucose will remain normal. So let me just do a quick recap of the topic of the pleural effusion. So if you see the normal quantity of the fluid in the pleural space, the normal quantity of the fluid which is accumulated within the pleural space, that is at a rate of 0.01 ml per kg body weight. So that is estimated to be around 5 to 15 ml in the pleural space, and the function of the fluid in the pleural space is to reduce the friction between the parietal and visceral pleura. And second important is this fluid in the pleural space will act as the shock absorber from the external injuries, and it is produced by the capillaries which are present within the parietal pleura, right? And it is also absorbed, right? It is absorbed by the lymphatics which are present in the parietal pleura. Now, what are the lymphatics? These lymphatics, they include the costal lymphatics, mediastinal lymphatics and diaphragmatic lymphatics. These are the lymphatics which will absorb the fluid which is produced by the capillaries of the parietal pleura, and there will be a balance of 5 to 15 ml in the pleural space, right? And when will be the clinical detection of the pleural effusion? The clinical detection of the pleural effusion is when the quantity of the fluid which is accumulated within the pleural space, it is around 300 ml. That will cause the clinical detection or the clinical signs. And the investigation of choice for the pleural effusion, that will be mainly the CT scan, and then followed by CT scan of the chest. Even it can detect 10 ml of the fluid as well. Then followed by that USG of the chest, right? Then followed by that, if you take the normal pleural fluid, what are the parameters? The normal pleural fluid, it has the pH of nearly around 7.60 to 7.64. That means slightly alkaline pH. And the protein, if you see in the pleural fluid, it is less than 2%. That is around 1 to 2 grams per deciliter is the normal quantity of the protein within the pleural space or in the pleural fluid, and fewer than 1000 WBCs per cubic millimeter will be present, and the glucose in the pleural fluid will be similar to that of the glucose in the plasma, whereas the LDH values, if you observe, that is lactate dehydrogenase, that will be less than 50% of the plasma, right? And depending upon the abnormal constituents, like we have various types of the pleural effusion that we called as empyema, where you have the presence of complete pus within the pleural space. That is what is called as the empyema. Next is the chylous effusion. So chylous effusion is that where there is excess amount of lymph within the pleural space. That is what is called as the chylous effusion. And in chylous effusion, there will be increased levels of, right? There will be increased levels of the chylomicrons, and there will be increased levels of the triglycerides. And the levels of the triglycerides, that will be greater than or more than 100 milligrams per deciliter. And this chylous effusion, what is the etiology? That is mainly due to disruption of thoracic duct. That will be responsible for the development of chylous effusion. Next important is the hemorrhagic pleural effusion. Hemorrhagic pleural effusion is that where you have the mixture of the blood and the pleural fluid. That is called hemorrhagic pleural effusion. And the number of RBCs in case of the hemorrhagic pleural effusion, they are nearly around 10,000 cells per microliter. That is hemorrhagic pleural effusion. Then we have the hemothorax. Hemothorax is that where you have the presence of the blood, and the number of RBC will be more than 1 lakh RBC per cubic millimeter. That will be the hemothorax. And this hemothorax, it is the presence of gross blood in the pleural space. Right, it is the presence of gross blood in the pleural space. And what is the etiology for the development of the hemothorax? The etiology causing hemothorax will be the trauma, right, or the instrumentation. And this particular hemothorax, it is defined as the ratio of, right, when will you consider it as the hemothorax? If the pleural fluid hematocrit to that of, right, to that of the peripheral blood hematocrit. Okay, so if this particular ratio, if it is more than 0.5, then we consider it as the hemothorax, right? And you need to know the pathophysiological process for the development of the pleural effusion. Number one, it is either due to increase in hydrostatic pressure or due to decrease in oncotic pressure. This will result in transudative type of pleural effusion. Second important is due to increased, right, this is due to increased capillary permeability, that will cause exudative type of pleural effusion. Number three, decreased lymphatic clearance, decreased lymphatic clearance, and that will result in the exudative type of pleural effusion. Next is infection within the pleural space, and that we call it as the empyema. And next is the bleeding into the pleural space. This bleeding into the pleural space, this we call it as the hemothorax. So these are the 5 important pathophysiological processes that will be responsible for the development of the pleural effusion. This pleural effusion, it is of mainly 2 types, transudate and exudate. Like if you take the, right, if you take the cause of the transudate, as already I have said you, that is due to increase in hydrostatic pressure or due to decrease in oncotic pressure. And exudate, that is mainly because of the inflammation of the capillaries, where there is increased capillary permeability. And if you observe the appearance of the fluid, it is completely clear in transudate. Because of the presence of the inflammatory infiltrate, it is cloudy in appearance in the exudate. And if you take the specific gravity, in transudate, the specific gravity is less than 1.012, and in exudate, it is more than 1.020. And in the protein content, if you observe, in the transudate, the protein content is less than 3 grams per deciliter, whereas in exudate, the protein content is more than 3 grams per deciliter. And if you take the fluid protein to that of the serum protein, the fluid protein to the serum protein ratio, it is less than 0.5 in transudate, whereas in exudate, it is more than 0.5. And if you take the fluid LDH to that of the serum LDH, in transudate, the value is less than 0.6, whereas in exudate, right, whereas in exudate, it is more than 0.6, right? And if you take these last 3 parameters, if any one out of 3 are positive, this we consider it as the Leitz criteria to be positive, right? Leitz criteria to be positive, okay? And if Leitz criteria is positive, that is suggestive of exudative type of pleural effusion. And what you have to remember is the fluid, it clots on standing in case of the exudate, but whereas the fluid, it remains like water and it will never clot in case of the transudative type of pleural effusion. And these are all the various etiologies that will be causing the exudative type of the pleural effusion. Out of all this, the most common cause will be the pneumonia, right? The other causes will be like tuberculosis, bronchogenic carcinoma, pulmonary infarction, then the ventriculoperitoneal fistula, esophageal perforation, collagen diseases or CABG, trauma, intra-abdominal abscess, ovarian hyperstimulation syndrome, numerous drugs like amiodarone and nitrofurantoin and the hydralazine, then ARDS, miscellaneous causes like yellow nail syndrome. So these are all the various etiologies that will be causing exudative type of pleural effusion. Whereas if you take the transudate, the most common cause for transudative type of pleural effusion is congestive heart failure. Then apart from that, the other causes include the hepatic cirrhosis, hypoalbuminemia, the myxedema or the hypothyroidism, Meek syndrome, peritoneal dialysis, the iatrogenic causes like extravasation or migration of the central venous catheter into the pleural space, the obstruction of the superior vena cava or obstructive uropathy, and then nephrotic syndrome. So these are all the causes for the transudative type of pleural effusion. Then we have a terminology called parapneumonic pleural effusion. This parapneumonic pleural effusion, it is completely divided into three categories: simple or uncomplicated, complicated, and as well as the empyema. Uncomplicated parapneumonic effusion is that where the individual will have the exudate in the pleural space, right? And along with that, there is also presence of the pneumonia. And these patients, they don't require any drainage. They will be requiring the antibiotic treatment. That will be uncomplicated parapneumonic effusion, where there is pleural effusion and upon that there is also pneumonia. Then you take empyema. Empyema, it's a gross infection of the pleural space, and that is indicated by the positive gram stain or the culture. And here you have the presence of pus in the pleural space. And these patients, they require, right, these patients, they require drainage by tube thoracostomy. That is what is your empyema. And in case of empyema, right, there is requirement to facilitate the clearance of the infection. That is what you observe in case of the empyema. Then you take complicated parapneumonic effusion. Complicated parapneumonic effusion, it is most difficult management decision. So here, in case of complicated parapneumonic effusion, the pH of the fluid, it will be acidic pH. The glucose levels in the fluid, that will be reduced. And there is also evidence of the loculation. That is what is your complicated parapneumonic effusion. Then we have, so that was about your three important forms of the parapneumonic effusion. Then malignant pleural effusion. Malignant pleural effusion is that which is commonly observed in case of the bronchogenic carcinoma, very commonly observed in the adenocarcinoma. Right, we have the adenosquamous cell and as well as small cell and large cell. But adenocarcinoma, the pleural effusion is like very common, malignant pleural effusion. And apart from that, breast carcinoma also will cause malignant pleural effusion. Then mesothelioma, that is a tumor of the pleura, even this will cause the malignant pleural effusion, right? Then in patients with malignant pleural effusion, if you observe the pleural fluid glucose, right, the pleural fluid glucose, this will be less than 60 milligrams percentage. And if you take the cytology, in the cytology, you have the presence of the malignant cells. You have the presence of the malignant cells, okay? And these patients with malignant pleural effusion, there is chance of recurrent pleural effusion. There is chance of recurrent pleural effusion. And to prevent the recurrence, right, so to prevent the recurrence, we inject the sclerosing agents. Right, we inject the sclerosing agents into the pleural space, and these sclerosing agents into the pleural space, they will cause the obliteration of the pleural cavity. And this particular procedure is called pleurodesis. This procedure is called pleurodesis, right? And this particular pleurodesis can be done by the talc. This can be done by the povidone iodine. This can be done by the injection of doxycycline into the pleural space via chest tube, right? So that is about the malignant pleural effusion. Whereas hepatic hydrothorax, it is a transudative type of pleural effusion. And what do you understand by this word hepatic hydrothorax? That means along with pleural effusion, there is also ascites. And this ascites, it is secondary to cirrhosis of liver. Right, this is secondary to cirrhosis of liver. Then what are the conditions where you have bilateral pleural effusion? Bilateral pleural effusion is observed in case of left ventricular failure. It is also observed in hypoalbuminemia, and it is also observed in the malignancy. So these are the etiologies that will be causing bilateral pleural effusion, right? Then there are certain conditions where you have predominantly left-sided, and there are certain conditions where you have predominantly right-sided pleural effusion. Predominantly left-sided pleural effusion, this is observed in patients with the acute pancreatitis, then in patients with esophageal rupture. Whereas predominant right-sided pleural effusion, this is very common in the amoebic liver abscess, right? This is very common in the amoebic liver abscess. And next is the cirrhosis of the liver, right? And the other important condition is Meek syndrome. So Meek syndrome is the condition which is characterized by a triad. Now what is a triad that you will have in case of the Meek syndrome is there will be ascites, there will be ovarian tumor, and there will be right-sided pleural effusion. And if you take the clinical features in these patients, they will have the exertional dyspnea, right? They'll have the development of the exertional dyspnea. Along with that, they'll have cough with chest pain. And that too, the type of chest pain will be the pleuritic type of chest pain will be there. And this cough with chest pain will be there mainly when there is development of the pleuritis. And the other clinical features, it all completely depends upon the underlying etiology that is causing the pleural effusion. And on examination, you will notice that on whichever side the pleural effusion is there, the chest wall movement will be reduced on the affected side. The trachea, if you observe, that is deviated to the opposite side, right? And upon percussion, there will be dull note. Vocal fremitus is reduced. Vocal resonance is reduced. Breath sounds are also reduced. So this will be on examination in patients with the pleural effusion. And these patients will also have the orthopnea. So upon lying down in supine position, they'll have difficulty in breathing, right? Because of the compression of the lung parenchyma by the fluid in the pleural space. And exactly opposite to that of orthopnea, we have what is called platypnea, where there is increase in breathlessness in sitting position, but they will be comfortable in lying down position. And this is very common in the tumors like the atrial myxoma and hepatopulmonary syndrome. They will have the platypnea, right? Then followed by that, you need to be aware of one important examination finding called succussion splash, which is present in patients with the hydropneumothorax. Now, what do you understand by this hydropneumothorax? Hydropneumothorax is that where you have the presence of the fluid and as well as air in the pleural space. That is what is called hydropneumothorax. And on auscultation, you will listen this succussion splash. So how is that you need to demonstrate this succussion splash? So you need to catch hold of the individual anteriorly and posteriorly, and you need to rigorously shake the individual. And upon rigorously shaking, you need to immediately auscultate with the stethoscope, where you will be able to listen the presence of the succussion splash. Okay, that is seen in case of hydropneumothorax, right? And in case of the hydropneumothorax, when you do a chest X-ray, right? In case of the hydropneumothorax, when you do a chest X-ray, the chest X-ray will show you the presence of the horizontal fluid level. So this is a X-ray of hydropneumothorax, and this is a X-ray of the pleural effusion, right? Then, if you take the characteristic features of the tuberculous effusion, it is usually exudative, right? And the the pleural fluid proteins, they are increased. The LDH levels in the pleural fluid is increased. And most of the time, the fluid, it is the hemorrhagic in nature, right? And the glucose level within the pleural fluid will be equivalent to that of the serum glucose levels, right? Will be equivalent to that of the serum glucose levels. And if you take the lymphocytes, there is elevated lymphocyte count. And if you take the ADA levels, the adenosine deaminase levels, that will be more than 45 international units per liter. And if you take this interferon gamma levels will be more than 140 picograms per ml. And these patients, there will be positive PCR for tuberculosis. So for tubercular DNA, there will be positive PCR. So this is about the tuberculous effusion. And what are the conditions where you have the low pleural fluid glucose levels that you observed in case of the malignant pleural effusion? You observe that in patients with the rheumatoid arthritis. You observe that in case of the hemothorax. And you observe that in case of the Church-Strauss syndrome. These are the conditions where you will have the pleural fluid glucose being reduced then compared to that of the plasma. Whereas in tuberculosis, the pleural fluid glucose will be equivalent to that of the serum glucose. And there are certain conditions where the pleural fluid amylase levels are elevated. That is, in esophageal rupture causing pleural effusion, pancreatitis causing left-sided pleural effusion, right? And malignancy, that is adenocarcinoma of the lung causing pleural effusion. In these conditions, the amylase levels are elevated, and there are certain conditions where the pleural fluid cholesterol levels are elevated that you observe in patients with the hypothyroidism, that you observe in patients with the tuberculosis, and that you observe in patients with the rheumatoid arthritis. So these are the conditions where the pleural fluid glucose levels are elevated. And how is that you will be diagnosing? The first line investigation will be the chest x-ray. And what does the chest x-ray shows? Chest x-ray, the earliest important sign will be the costophrenic angle that will be blunting of the costophrenic angle. Then you have the presence of the Ellis S-shaped curve, right? Then you take the trachea that is shifted to the opposite side, and you have the presence of the homogeneous opacity within the chest x-ray. So this will be the chest x-ray picture in patients with the pleural effusion. And CT scan, it can identify even the presence of 10 ml of the fluid also. And what is the usage of the ultrasonography? That is mainly for the safety of thoracocentesis and making out the exact point where the thoracocentesis has to be done. The ultrasonography is of important thing. Then when do you call it as the massive pleural effusion? Massive pleural effusion is that when the entire hemithorax, right, when the entire hemithorax, when it is opaque, right, when the entire hemithorax it is opacified, then we call it as the massive pleural effusion, right? Then the treatment is, you need to treat the underlying cause. That is the first important thing. Then you need to be aware of the indications of thoracocentesis. Number one, diagnostic thoracocentesis. Then what is the indication for therapeutic thoracocentesis? The indication for therapeutic thoracocentesis is when the distance between the pleural surface and the lung border, if it is more than 1 centimeter, right? If the distance between the pleural surface and lung border, if it is more than 1 centimeter, then you need to do therapeutic thoracocentesis. And therapeutic thoracocentesis, it should be done by inserting the needle within the 7th intercostal space. And this 7th intercostal space along the scapular line, right? Along the scapular line. And this should be always done by standing behind the patient, right? And if we have done on the mid-axillary line, there is chances of development of the pneumothorax. And whenever you are taking out the fluid, you have to take the fluid of less than 1.5 liters. And if you take more than 1.5 liters, there is chance of development of re-expansion pulmonary edema. That is about the thoracocentesis. Then what is the indication for the ICD tube insertion? Mainly whenever there is loculated pleural effusion, you need to place the ICD. And if there is a development of empyema, you need to place the ICD. When the pleural fluid pH, if it is less than 7.2, you need to place an ICD. And if the pleural fluid glucose, right, if the pleural fluid glucose, if it is less than 60 milligrams per deciliter, then also you need to place the ICD and take out the fluid. And next important is, what is the indication for injecting the fibrinolytic agents? So what are these fibrinolytic agents? That includes the tissue plasminogen activator, right? And this mainly whenever there is loculated pleural effusion, mainly when there is loculated pleural effusion, you need to inject the fibrinolytic agents, and the entire loculations that will be completely cleared. Following that, you need to do the drainage. Okay, so intrapleural tissue plasminogen activator, and how much will be that? 10 milligrams, right? And deoxyribonuclease 5 milligrams have to be injected into the pleural space. And if there is recurrent pleural effusion, because in patients with loculated pleural effusion or in malignancy, there is chances of recurrent pleural effusion. In this case, you need to do decortication, right? In this case, you need to do decortication. That should be considered if the medical management is ineffective. So this is about the quick revision of the topic of the pleural effusion. So the next important question is on the topic of the idiopathic pulmonary fibrosis. Which of the following are correct regarding the idiopathic pulmonary fibrosis? The radiological pattern of the usual interstitial pneumonia. Second, the presence of the finger clubbing. Third, more commonly in the elderly individual. Select the correct answer using the code given below. So these patients with idiopathic pulmonary fibrosis, they'll have the radiological pattern of the usual interstitial pneumonia, that is correct, which is nothing but the interstitial pattern on the chest x-ray. Finger clubbing will be there, and this idiopathic pulmonary fibrosis, this is more common in the elderly individual. Now you take this particular clubbing, what are all the various respiratory conditions where you can have the presence of the clubbing is cystic fibrosis, interstitial lung disease, and your idiopathic pulmonary fibrosis, it is one of the form of the interstitial lung disease, right? And third important condition is bronchogenic carcinoma, next bronchiectasis, then the other condition will be the lung abscess, then next important condition is empyema, right? And followed by that necrotizing pneumonia, right? Necrotizing pneumonia. So these are the conditions, respiratory conditions where you have the presence of clubbing, right? And if you see the discussion of the idiopathic pulmonary fibrosis, this is one of the chronic lung disease, and that too it is a chronic progressive lung disease which is characterized by thickening and as well as scarring of the lung tissue, where there will be fibrosis of the lung tissue, and what exactly is the etiology is not known, right? And if you take the etiology, that is idiopathic, the exact cause is not known, so that is the reason why we call it as idiopathic pulmonary fibrosis, right? However, there are some genetic factors, environmental exposures that would be responsible for the development of this idiopathic pulmonary fibrosis. And these environmental exposures, that includes smoking, right? And exposure to the pollutants and exposure to certain dusts, right? Exposure to certain dusts. So these are the etiologies that will be responsible for the development of idiopathic pulmonary fibrosis. And if you take the pathophysiology in idiopathic pulmonary fibrosis, the lung alveoli and interstitial tissue, they become, so it is both the alveoli as well as the interstitial tissue, right? It becomes scarred. Okay, alveoli and interstitial tissue, it becomes scarred over time. And this fibrosis disrupts the normal architecture and the functioning of the lungs. Thereby, there will be reduced gas exchange, right? Thereby, there will be reduced gas exchange. And the scarring typically progresses over months to years, and that will result in the decline of the lung function, right? So that will result in decline of the lung function. So this is the basic pathophysiology. And if you take the clinical features in these patients, the very important clinical feature will be dry cough, right? Then there will be also progressive dyspnea, right? That is the shortness of breath, right? And this shortness of breath, it is mainly upon the exertion. Then followed by that, these patients will also have the development of the fatigue, and they also have weight loss and as well as clubbing. So these are the clinical features that you come across in patients with idiopathic pulmonary fibrosis. And on examination, there will be crackles, and these crackles, they are the Velcro crepitations which are heard in the lung during auscultation. And on examination, you also have clubbing in patients with the idiopathic pulmonary fibrosis. And how is that you will be diagnosing idiopathic pulmonary fibrosis? It is by imaging, right? And in the imaging, it is the HRCT, that is high resolution CT scan, will show the characteristic pattern of the fibrosis, and such as honeycombing, right, honeycombing, and as well as the reticulation. That is what you will observe upon imaging. And pulmonary function test will show you the restrictive pattern where the FEV1 by FVC, either it is normal or increased. And what will happen to the diffusion capacity of the lung for carbon monoxide? The diffusion capacity of the lung for carbon monoxide is also decreased. And if you take the histopathology, the lung biopsy may be required in some cases to confirm the diagnosis. Okay, so lung biopsy, it is required to confirm the diagnosis, and you need, by doing the lung biopsy, you will be able to exclude the other causes of the interstitial lung diseases. And in the management of the interstitial lung diseases, medications like anti-fibrotic agents should be given, right? Now, what are these anti-fibrotic agents? These anti-fibrotic agents, example, pirfenidone, right? That is one important molecule. And second important molecule is nintedanib. Okay, so pirfenidone and nintedanib, this will slow the progression of the disease. And apart from that, the supportive care, that is the oxygen therapy, should be given for hypoxemia, and pulmonary rehabilitation, right? Pulmonary rehabilitation. And then followed by that, the lung transplantation. So lung transplantation, that should be considered for eligible patients in advanced disease, right? So in advanced disease, the lung transplantation has to be done. And how is the prognosis in patients with idiopathic pulmonary fibrosis? Usually the prognosis is poor, where the median survival, right? The median survival, it is around 3 to 5 years after the diagnosis. And the disease course can vary, with some patients experiencing rapid deterioration and others having a more gradual decline. So this is about the idiopathic pulmonary fibrosis, right? Coming on to the next question. As per 𝐒𝐮𝐬𝐜𝐫𝐢𝐻𝐿 classification, farmer's lung is which type of the hypersensitivity reaction? 1, 2, 3, 4. So the farmer's lung, right, it comes under type 3 hypersensitivity reaction. Now, what exactly is your type 3 hypersensitivity reaction? It is immune complex, right? It is immune complex mediated hypersensitivity reaction. Now, how many types of hypersensitivity reactions are there according to the 𝐒𝐿&COMBS? According to the 𝐒𝐿&COMBS, there are totally 4 types of the hypersensitivity reaction. Now, type 1 is the immediate hypersensitivity reaction, and the mechanism is, it is IgE mediated, where there is increase in IgE antibodies. And in this condition, right, in this condition, when the allergen, right, when the allergen, it binds to IgE on the surface of the mast cells and basophils, there will be release of the important mediator, that is the histamine. And this particular histamine will cause the bronchoconstriction. And what are the examples of the type 1 immediate hypersensitivity reaction? That includes, number 1, allergic asthma, right? And number 2, hay fever, right? Number 3, anaphylaxis. And number 4, the food allergies, right? Number 4, food allergies. Okay, so these are the causes, the etiology is causing type 1 hypersensitivity reaction. Then you take type 2, that is cytotoxic hypersensitivity. So the mechanism here it involves is the IgG or IgM antibodies, right? IgG or IgM antibodies, which are directed against the cell surface or extracellular matrix antigens. And this leads to the cell destruction via complement activation or antibody dependent cell mediated cytotoxicity. Okay, and the examples of type 2 hypersensitivity reaction will be Goodpasture syndrome, next hemolytic anemias, right? Number 3, myasthenia gravis. And number 4, transfusion reactions. Right? Number 4, transfusion reactions. Okay. So this comes under type 2, that is cytotoxic hypersensitivity. And type 3 is the immune complex mediated hypersensitivity reaction, where there is formation of the immune complexes, right? And these immune complexes, they are deposited within the tissues. And the immune complexes which are deposited in the tissues, they will cause the inflammation, right? They will cause the inflammation and as well as the tissue damage via complement activation. And examples of this immune complex mediated hypersensitivity reactions are, that is the farmer's lung, next systemic lupus erythematosus, next rheumatoid arthritis, next post-streptococcal glomerulonephritis, and then the serum sickness. Okay, so these are the etiologies that will be responsible for type 3 hypersensitivity reaction. And type 4 hypersensitivity reaction is delayed type hypersensitivity reaction. Here the mechanism involves, right? Here the mechanism involves T cell mediated immune response, right? And the cells which are involved here is the CD4 plus T cells and as well as the CD8 plus T cells. These are the cells which are involved in delayed type of the hypersensitivity reaction. And the examples of the delayed type hypersensitivity reaction, that includes the tuberculin test, right? That includes the tuberculin test. And the next important is the contact dermatitis, right? Contact dermatitis, which is poison ivy. Then granulomatous diseases like tuberculosis and as well as the sarcoidosis. So these are the examples of the delayed type hypersensitivity reaction. So these are the 4 important types of hypersensitivity reaction according to the Gell and Coombs, right? Then followed by that, the next question, a decline in total lung capacity to less than 80% of the patient's predictive value is indication of restrictive lung disease, obstructive lung disease, pulmonary arterial hypertension, pulmonary embolism. So total lung capacity, it is reduced in case of restrictive lung disease, but not in case of the obstructive lung diseases. And examples of restrictive lung diseases will be number 1, sarcoidosis, number 2, pneumoconiosis, right? Number 3, interstitial lung disease, number 4, drug-induced fibrosis of the lung, right? Now out of this, let me discuss about this sarcoidosis. So if you take this sarcoidosis, it is the disorder where you have the presence of the non-caseating granuloma, right? And what are the other conditions where you have the presence of the non-caseating granuloma? Non-caseating granuloma, it is also observed or it is also seen in cases of the ulcerative colitis. And in this granuloma, you have the presence of the inclusion bodies. And these inclusion bodies, they are number 1, Schaumann bodies, number 2, the asteroid bodies, number 3, residual bodies, right? Number 3, residual bodies. So these are the examples, these are the inclusion bodies that are observed in the granuloma. Whereas you take the caseating granuloma is observed in case of the tuberculosis, whereas in sarcoidosis it is a non-caseating granuloma. And the most common organ which is affected in case of sarcoidosis is the lung, and that will be in the form of the interstitial lung disease, right? Or there can be also development of the pleural effusion, right? And in these individuals, the next important manifestation is bilateral hilar lymphadenopathy, and that can be observed on the chest x-ray. And the skin manifestation will be in the form of the erythema nodosum and as well as the lupus pernio. I'll show you both of these images. And cardiac manifestations will be in the form of the restrictive cardiomyopathy. And what exactly will be the cause of death in patients with sarcoidosis? This restrictive cardiomyopathy can throw arrhythmias. And this arrhythmias would be the cause of death in patients with the sarcoidosis. And not only that, angioinvasive mycetoma can also be the cause of death. And the ophthalmic manifestation in patients with sarcoidosis will be the development of uveitis, and CNS manifestation will be in the form of lymphocytic meningitis, and there will be also the involvement of the 7th cranial nerve. And the investigation of choice in patients with sarcoidosis is the biopsy. Biopsy will show you the presence of non-caseating granuloma and the inclusion bodies such as Schaumann bodies, asteroid bodies, and as well as the residual bodies. And then you need to do gallium scan. This particular gallium scan is the one which will show you the two important signs, that is the lambda sign, and second one is the panda sign. Okay, so lambda sign is that where there is increased gallium uptake within the bilateral hilar lymph nodes and right paratracheal lymph node. And panda sign is that where there is increased gallium 67 uptake in the parotid gland and as well as the lacrimal gland, and that will give rise to the panda sign. And chest x-ray, it will show you the bilateral hilar lymphadenopathy, and it will also show you 1, 2, 3 sign, right, or the pawnbroker sign. So what do you understand by this 1, 2, 3 sign? That is, there is bilateral hilar lymphadenopathy. Along with bilateral hilar lymphadenopathy, there is also right paratracheal lymph node enlargement. That is what is the chest x-ray. And how is that? You will treat the patient with the sarcoidosis, that is by supplementation of the steroids, that is prednisolone. Now let me show you the images in sarcoidosis. So number 1, the lupus pernio, where you have purple blue rash over the face, and this will be erythema nodosum, where there is inflammation of the subcutaneous tissue, and this is the bilateral hilar lymphadenopathy, which is very classical in sarcoidosis, and this will be the Garland striate or 1, 2, 3 sign, or this is also called as the pawnbroker sign. Why? Because in this, along with the hilar lymphadenopathy, right, there is also right paratracheal lymph node enlargement. This is what is called Garland striate. Then next you have lambda sign and as well as panda sign, and that can be made out by the gallium 67 uptake. And if you take the diagnosis, that is by bronchoalveolar lavage. Bronchoalveolar lavage will show you that there is lymphocytosis, and if you take the CD4 to CD8 ratio, right, CD4 to CD8 ratio, that will be more than 3.5 in the bronchoalveolar lavage fluid. And what will happen to the angiotensin converting enzyme levels? That will be elevated, and even there can be elevated calcium levels upon the blood examination. So this will be the laboratory test, and the treatment is what? It is mainly the steroids, and among the steroids, that is prednisolone, that is considered to be the first line treatment. But in those individuals who are like on long term steroids, they may develop Cushing's. The steroid sparing agents, that will be hydroxychloroquine, right? This is alternative to steroids, especially with lymphopenia. And methotrexate, that is also alternative to the steroids, right? This is also alternative to the steroids or steroid sparing agent for sarcoidosis. And azathioprine, it is another third option as the steroid sparing agent. And in refractory cases of the sarcoidosis where the patient is not responding to the steroids or methotrexate or azathioprine, in that case you need to give the infliximab. So this is about the sarcoidosis, which is the restrictive lung disease, where the total lung capacity can be reduced to less than 80% also. Then one important obstructive lung disease that we need to definitely discuss is about the cystic fibrosis. So cystic fibrosis, if you observe, it is an inherited disorder, and the type of inheritance is autosomal recessive type of inheritance, and it is mainly due to mutation of this particular gene, that is CFTR gene. And this CFTR gene, it is located on the 7th chromosome. And what exactly is the abnormality in the CFTR gene? That is mainly due to deletion of the delta F 508 mutation. That is what is responsible for the CFTR gene to be mutated, and it is a multi-system disorder. GI manifestation mainly in the newborn, that will be in the form of the meconium ileus. These patients will be requiring the gastrographin enema, and respiratory manifestation will be in the form of the recurrent pneumonia. And apart from that, there will be also the upper lobe bronchiectasis, which can be seen in patients with the cystic fibrosis. And these patients, they will also develop and the gastrointestinal manifestation in adults, that will be in the form of the secondary biliary cirrhosis, right? That will be in the form of secondary biliary cirrhosis. And there will be also development of the osmotic diarrhea, and infertility is observed in males, and that infertility in males, that is mainly because of the azoospermia, right? It is caused due to agenesis of the vas deferens, right? And in females also there is infertility, and that is due to increase in the thickness of the cervical mucosa, and thereby the sperms cannot pass through the female genital tract. And what exactly is the investigation of choice, right? That is genetic analysis, where you need to do a CFTR gene analysis should be done, and the screening test will be the sweat chloride test, right? The sweat chloride levels, they will be increased, and that will be more than 60 milliequivalents per liter. Then coming to the treatment, these patients, they will be requiring the drugs which will cause the alteration of the CFTR gene, right? And that these are the drugs that will improve the patient's lifestyle. So these are considered as the potentiators of the CFTR channel. Examples are the ivacaftor, right? Apart from this, we also have lumacaftor, tezacaftor, and then elixacaftor. But ivacaftor is one of the important molecule. These are considered as the CFTR trafficking drugs. And because these patients are at risk of recurrent pneumonias, the broad spectrum antibiotics, they form the mainstay of the treatment. And you need to give 7% saline nebulization, that is mainly to liquefy the thick sputum that is being produced in patients with the cystic fibrosis. So this completes the discussion of cystic fibrosis, and this finishes the quick revision of the entire pulmonology. Thank you very much.